Hello, I'm Dr. John Cruz, and today I'm having a question and answer session. It's supposed to be based on using as a launching pad the talk I released a few days ago on CBT and panic. If you are looking for that video, unfortunately, I'm on vacation. I'm traveling right now, so I did record it. I thought I had uploaded it, and I thought it was ready and scheduled for release on Saturday. But I've been traveling since Friday, and yesterday I discovered that there was a loading problem. So do not feel foolish or that you couldn't find it. It's not there yet. I will be home later this evening and try to retrieve it or upload it and post it then. So sorry for that. And launch. So I'm going to sort of recap maybe 5, hopefully less than 10 minutes, definitely less than 10 minutes, what I talked about, and then I'll be open for questions and answers on this topic or any other topic. So to begin with, panic attacks are common. And why are they common? Everyone is susceptible to them. Everyone is susceptible because everyone has within their head a panic system or a panic center. It's actually an emergency relief, an emergency alert system. So we need that because there are emergencies in life when we need to respond quickly and we don't have time to calculate how to deal with it. We just need to react. But the panic attacks, as I'm defining them, and it's close to the official definition, are when the emergency alert system goes off, but there is no danger present. And what's happening at a slightly more sophisticated level is your interoceptive nervous system. So that's the nervous system that collects information throughout your body and through your senses. So what you see, what you're feeling inside, all that information is constantly being surveilled for something different, something different, something different. And when it picks up something, it reports it back to the brain so the brain can deal with what's different. And in panic, what happens is that this is different, makes a leap to, oh my God, this is dangerous. And that's what triggers a panic attack. So discharge of the amygdala, unleashing of the sympathetic nervous system. Your body's flooded with chemicals and neurotransmitters that activate, make your heart pound, make your breathing short, cut off blood flow to the digestive system so you have nausea, increase blood flow to the big muscles so you're ready to run and get the hell out of there, and also shunts blood flow in the brain differently, so it really is harder to think. So the cognitive behavioral therapy approach to panic is twofold. One is you have to identify that it really is panic that's going on, and then it is at the most simple level, and it really can be this simple, which does not mean that it's easy, is telling you, no, this is just a panic attack. This is something your brain started. It's responding to something in the world, but that does not mean you're in real danger. It picked up something that was different and it made a leap to danger. This is not dangerous. You are safe right now. And once you're aware of that, you can help work on shutting down your sympathetic nervous system, changing those physical symptoms, which are actually causing feedback loops, perpetuating the panic, and get out of this panic attack more quickly, make this and subsequent attacks more mild rather than going all the way to the tippy top. And over time can retrain your system so that it's less sensitive to being triggered again. So important point I made there is that panic attacks, even though they are in many ways our most dramatic and physical psychiatric symptoms, partly because of that, partly despite of that, they're often misdiagnosed. So and they're misdiagnosed both ways. So real panic attacks when they happen are fairly often, the doctors are convinced this must really be something going on with this person's heart, lungs, something else, primarily a bodily function or crisis. And on the other hand, particularly patients who already have a psychiatric label or are presenting strangely at the ER, often when they have real somatic, which is bodily illnesses, they are misdiagnosed and dismissed as panic attacks. So the sensitivity of your emergency alert system varies depending on your genetics and also depending on life experiences. So that can reset, can make really sensitive systems more placid if you got a very supportive, nurturing family environment. Even if you have a fairly resilient panic center and you're exposed to lots of trauma, that can certainly make it more sensitized and easier to trigger. Situational factors certainly can increase the likelihood that you are going to have a panic attack, so decrease the trigger threshold, particularly sleep deprivation. Also, any physical illness. So even if you have a little cold, that means already your interoceptive system is getting lots of information. Your nose is stuffed up, your eyes are running, you have a cough, whatever. Your body is getting all this information. This is weird, this is weird, this is different, this is different. So physical illness, mental conditions, depression, PTSD, anxiety, ADHD are all associated with higher rates of having a panic attack. Just being in a new situation, you're more hypervigilant, you're more wary, you're more ready to be triggered, and a host of medications, drugs, and other chemicals in the environment can make panic attack more likely. So again, when cognitive behavioral therapy works for panic, we know that it does make changes in your neurochemistry and neuroconnectivity. So it's not just, some people think, talking therapies are here talking and, medicines are what really change brains. It's certainly both these can affect brains and have positive effects. And virtually all the symptoms, the physical aspects of panic attacks are hyperarousal of the sympathetic nervous system. And part of the more detailed level of dealing with cognitive behavioral therapy is explaining, yes, there was some real trigger or set of factors which triggered something, but what happened was an event in your brain that was an over response to what's going on in the environment. And this ongoing over response is not necessary or helpful and actually feeds back and creates more signs to your body that something's wrong, something's off. So the heart rate pounding, shortness of breath, nausea are all signs of sympathetic nervous system overactivation. And including one key one is that within the brain, blood flow is shunted differently. So you have less ability to employ your cognitive thinking to get out of a panic attack, which is why all the panic approaches need to be practiced over and over again, so they are over practiced and become the default, so that when you are in it, you don't need to be thinking, you need to just be pulling a prepared response off the shelf. The last thing I'm going to say before looking for questions, again on this or other topics, is that panic often induces shame, and there should not be any shame connected with it. To begin with, what it's unleashing, again, everyone has a panic center. It's not just weak people or crippled people or bad people. Everyone has potential to have panic attacks. And what's unleashed is a largely out of your control, once it starts happening initially, set of physiologic responses. So you're not imagining them, these are real, those are happening. Again, not shameful. It's also not shameful not being able to immediately recognize panic. Often it's easier for someone outside the panicker to notice that this could be panic. Part of it is because at the core of panic is telling many lies. And one of the lies is, oh my God, this is real. This is a real emergency. You need to get the heck out of here. You need to do something. You need to run or flee. And the third thing that I often run into people who feel shame about CBT and dealing with it is that, particularly if they're being reassured or a therapist is talking them through it, they feel shameful that they need so much repetition, that they can get some things intellectually before they feel the reality of them. And what I tell people is, one, that's how CBT works. Lots and lots of repetition. And why does CBT work that way? It's because that's how brains work. Human brains need lots and lots of repetition to learn most important life lessons. So that's the recap, and I will look for questions. I also have some prepared topics to go into. I'm not seeing, and again, I'm open to topics on CBT for panic. I'm open to any questions on ADHD or anything in mental health in general, and I'm not seeing anything coming in right now. So one written question I had was, whether CBT and cognitive behavioral therapy, CBT, which is cognitive behavioral therapy, and medications work the same way when they help with panic. And the evidence so far is that there is some overlap, but they are doing distinct and different things. Again, when CBT is effective, it does result in changes in neurochemistry and in the strength of different connections within the brain. A very gross oversimplification is that some of the older theories that CBT works through what's called top-down, so thinking and controlling things to influence lower emotional or primitive older emotional centers, and that medications may work more directly on some of those primitive centers. And again, these are in parts of the brain that are in communication with each other, but there actually is some evidence that that is a valid statement, that there's probably bigger effects of CBT on the prefrontal cortex, anterior cingulate cortex, than there is directly on the amygdala. Again, that can result, and it's activating or engaging some of those top-down centers to quiet down the amygdala, quiet down the basis of the response. So I do see a question. I don't even know if sound is working with this setup. So Max Doppler asks, hello. So hello. He's prescribed Ritalin. He worries how his body will react to this drug in general. He thinks that he's sensitive to coffee. Is it an indication that this can make me anxious and nervous as well? So it's a really good question. So caffeine is labeled a stimulant, a mild stimulant. Most of the evidence suggests caffeine's main effect is on adenosine systems, and it has indirect dopamine effects. So my experience, so I do not know any rigorous research on whether sensitivity to caffeine predicts sensitivity to Ritalin. So this is more my cognitive, or my clinical experience, and based on my distillation of the published literature on these two things. So yes, I think there is a general correlation. So in general, feeling very sensitive to caffeine may make you a little more likely to be sensitive to Ritalin. On the other hand, they are different chemicals. They are working different ways. And I've seen numerous individual cases where people were wired and couldn't ever take caffeine and have no problem with Ritalin. And I've seen the reverse as well, or Adderall, that someone could tolerate lots of caffeine and felt wired on the prescription medications. So what I would say is your past experience by a distantly related medication is information to be aware of. And the starting place would still be, as it usually is with someone starting a stimulant, start at and what I should clarify is I can't make specific medical recommendations or advice. I clearly have not evaluated you. But my general advice and general information is we usually start at low doses and see how someone responds. If there's some mild, tolerable amount of feeling overactivated, we usually recommend staying at that same dose for a few days in a row. And most often that starts to taper off or diminish, whereas benefits are more likely to be retained over time. But if either that overactivation sensation is not decreasing, and worse, if it's increasing, then the response would be that probably isn't a good medication for you. And the other part of the protocol is not to spend too long on any given dose. So and I usually think 2 or 3 days for most people is reasonable. We know there's lots of day-to-day fluctuations in ADHD symptoms, and I use ADD and ADHD interchangeably. So we know there's lots of day-to-day variability. So one day in itself doesn't definitively show what the medication is going to do, but most of the stimulants have most of their benefits pretty quickly the day you take them. So if after 3 days, if you're seeing no benefits, you're seeing no side effects, then there's no point in sitting longer at that low dose. You should go up. And a typical picture would be starting really low at 5 milligrams of Ritalin and going up to 10 after 2 or 3 days if you're not seeing much, and every 2 or 3 days to keep going up if you're not seeing any bad effects, any side effects, and if you're not seeing any benefits. If you're seeing only benefits and no side effects, great. And some people recommend stopping when you get what feels like an adequate effect. Other people recommend, benchmark, write down what that dose is where you're seeming to have some positive effect, but it may be worth going even a step or two higher because you may get more full benefit than you might appreciate you can get if you're not that aware of. Part of ADHD is disrupted awareness of what's going on with your body, what's going on around you, less attentiveness. So that's my general recommendation. So Amadi says, can I take 3 short-release tablets of methylphenidate instead of taking a sustained-release tablet 54 in the morning? So again, I can't make specific medical recommendations. What I can say is, in general, the long-acting forms are supposed to replicate the repeated delivery of 2 or 3 or 4 or 5 or however many more. So the medication should be the same. So again, the extended release, things like Concerta and others, were designed to replicate what you would get from taking the medication 3 times a day, but to save you the bother of having to remember additional doses, and particularly for kids, for having to take additional doses and have them administered during school hours, where they may be subjected to inadequate nursing in the school or peer pressure to take it or to have it stolen from them. Anyway, and getting back more specifically to your question, the claim most often repeated, and it's a general clinical, and what I see, is that approximately the total milligrammage, so if you are taking 54 as one single extended release, that's generally the same effect you would get from 318, so total of 54 in the immediate release form taken 3 times during the day. So usually milligram daily dose is kept fairly stable when switching between immediate to extended release or extended release to immediate release. So Sniper Channel saw my video about Cymbalta for ADHD. So Cymbalta, so Sniper saw my video on Cymbalta, which is duloxetine, which is a norepinephrine and a serotonin, so two different modes of action medication. It's never been approved for ADHD. It's approved for depression and anxiety. And someone's knocking at the door, so I'm distracted. I'm in a hotel room right now. So yes, would it be better? So lots of people have side effects with atomoxetine. Lots of people can't tolerate it. And so if the atomoxetine Strattera is working well for you, I wouldn't necessarily switch. Again, atomoxetine is FDA approved for ADHD. There are clearly many individuals who it does well by. I think much of its action is immediate, and it's just that most people can't tolerate dose, but there is, in most research, a cumulative benefit from being on it for a long period of time. On the other hand, even if ADHD is well treated by your atomoxetine, but you're having substantial problems either with anxiety or depression, then it's moderately likely, I would say, that Cymbalta would be better. I mean, I see Cymbalta duloxetine as better tolerated and usually more effective for a broader range of symptoms. But again, if Strattera atomoxetine is working for you, great. So Dylan N asks, is CBT good for OCD? So the things I would say about OCD is even our medication. I mean, lots of people criticize how well our antidepressants, our SSRIs, work for depression, or some claim they don't. I'd say that the established research, body of research, is overwhelming, particularly if you look at the effects on dogs and other creatures where placebo effect should be minimal. Anyway, medications don't work nearly as well for OCD as for depression. So with depression, very often we can completely cause depression to remit. We can cause a disappearance, total disappearance in depressive symptoms. With OCD, with medications, usually the best response, there's some individuals who have get total relief. Usually it's decreasing the frequency and intensity markedly. So CBT for many people can work as well. And if I'm using CBT broadly to include certain specifically habit reversal techniques and substituting one habit for another. So yes, CBT is good and effective for OCD, just like anything. There's, everyone, no cure works for everyone, and the great and wonderful thing about CBT, and I talked about it in the 25 minutes, is that it can be largely self-taught. So there are very good resources online and in your library for learning CBT techniques. Usually an astute therapist can speed the process along, can serve as a second set of eyes to look at things you may not be aware of or may not be perceiving. But the wonderful thing is a lot of it can be self-taught. So Max also asks, so he was, and I'm assuming it's a guy, I can't see the little picture too well. Should I quit drinking alcohol forever while taking, and he's the one who's about to start Ritalin. I was told that nicotine and alcohol interact with many drugs and I should avoid it. I don't want to ruin its effects. So I do have an older, one of the earlier talks, videos here is on alcohol. I'd say in the probably 3 years since I posted it, there's been much more consensus and much more studies. Alcohol, sorry folks, is not your friend. It sucks for any brain, particularly if you have a propensity for depression or anxiety. My strong recommendation is avoid it as much as possible and your brain will thank you. I won't actually say that about nicotine because there's actually some evidence that nicotine has beneficial effects for ADHD. The downside is smoking or vaping have their own health risks with it. So nicotine, maybe gum or patches, which are quite expensive and in many countries controlled via prescriptions, are a better way to go if nicotine is your drug of choice. So Sniper Channel has another question. Is vilazodone used for ADHD insomnia or any other sleep aid is also good? Getting good sleep is certainly highly desirable and one of the most important aspects of ADHD treatment. Some of my earliest videos, and maybe I'll update them, are on addressing insomnia and sleep problems. I would concur with almost all of the sleep experts, and I would say almost all is probably upwards of 95%, who strongly push behavioral, including cognitive behavioral for insomnia approaches above medications, because almost all of our medications, even the ones that are FDA approved and work, are shown to have some effect, most of them, the longer you use them, the less effective they become. CBT, on the other hand, the more you use it, tends to be more effective. My choices for sleep medications, and I have a video on this as well, are the DORA agents, the dual orexin receptor antagonists, things like Belsomra, Davijo. Those are, so most of our sleep agents are piling on sedation, whereas the DORA agents are shutting down daytime activation that should be shut down at night. So having a regular sleep cycle, good sleep hygiene. I use trazodone. I don't particularly use vilazodone. I don't know the studies specifically sorting out how well vilazodone helps with sleep. I certainly have some ADHD patients who take guanfacine at bedtime and feel that it helps with insomnia and helps with sleeping. And we know two things about stimulants and insomnia. There certainly are some people, particularly with long-acting drugs, but not only, even many with just a short-term stimulant early in the day, it still revs them up later at night and makes it harder to sleep. On the other hand, a probably at least equally sizable segment of the population sleeps better. It might be that they're more awake, alert during the daytime and more productive, and it's easier for them to shut down their brain at the end of the day. I also, and I've talked about this on one of my videos as well, there's a small percentage, a small but sizable minority of people with ADHD who take a small dose of a stimulant, Ritalin, Adderall, right at bedtime, because that helps them sleep. And it helps them sleep, it might sound paradoxical, because it helps them contain their thoughts and turn them off rather than have them bouncing everywhere and uncontrollable. So thanks, Sniper Channel, for the thumbs up and liking the channel. So Dylan R asks, getting back to the OCD and rumination, I think part of the OCD approach, similar to the CBT approach for OCD, like it is with panic, it's sort of labeling and saying, these are ruminations, these are not real concerns or worries. Can we put them in a box? Can we give them this label? Not try to ignore them, because ignoring things, both in panic, OCD, depression, or anxiety, tends to make things grow larger. It's saying, acknowledging them, thanking that part of the brain for presenting that information to you, and saying, but I don't have to accept your assessment and go with your judgment as to why I need to focus on it. And I've also talked about, rumination suggests you're overly stuck in the default mode network. The three basic approaches I have for that is, one, almost anything you can do to engage in the real world instead of inside your head. So use your senses, see how many different red objects you can find around you, look to hear how many levels of noises or sounds you can hear in your background. Try to connect socially, even if it's with the cat who's walking across your keyboard, but anything that pulls you out of your head is helpful. Second thing is the meditative network is a different network in the brain than either the salience and executive networks or the default mode ruminative network. So meditation can be a powerful way to get out of rumination. I would not recommend for most people starting with a blank, try to clear your mind, because that's a setup for just ruminating, but maybe something that's either using a visual imagery, so you have something to focus your mind on instead of your ruminations, or a progressive muscle relaxation, so you're also following a script but paying attention to your body, or yoga, where you are actively engaging your body, or mantras. And I have a talk on mantras, a video on mantras in the series, where mantras seem to be a very effective and easy, one of the easiest ways to tap into that meditative network. So it's repeating a short phrase that gets you out of that ruminative default mode network. So Dylan mentions that alcohol alleviates his OCD completely, but the rebound effect is worse. So that's one of the big downsides of alcohol. Alcohol works for anxiety. It is clearly effective. The downside, so if this is your anxiety level, most drugs or substances that cause a decrease in anxiety wear off after time, and then they don't leave you right at your baseline. They actually have an increase. So there's what's called rebound increase in anxiety. So this is particularly the acute agents, not necessarily the serotonin reuptake inhibitors or Buspar, which act very slowly and indirectly. So drugs, including alcohol, that immediately decrease anxiety cause rebound increased anxiety. And the bad things, well, first the good part. If it lowers your anxiety this much, it isn't likely to elevate it above its baseline that much. So the extent or magnitude of increased anxiety is not nearly usually as big as the decrease or benefit you got. But the downside is that the duration of the withdrawal effect is usually, and the rebound anxiety is usually 3 or 4 times longer than the acute effect. So alcohol, most people feel less anxious for 2, 3, 4 hours, and then maybe 6 hours, and then for 3 times as long, 12 to 18 hours, are feeling slightly more anxious. And if you drink during that time, you're going to treat your anxiety that's both due to rebound and due to any residual anxiety that was there anyway. So that is part of the setup for these drugs, such as alcohol, being addictive. So Max shares his experience that atomoxetine Strattera seemed to work for 2 to 3 months in calming him down, that made him sleepy and had other bodily effects that just made it not worth it. So Sniper was asking about trazodone, brand name Desiril, but almost everyone calls it just trazodone. It's helping with sleep. I use it. I've prescribed it a lot for sleep. I think it's good. There's needs to be confirmed evidence that unlike some of the benzodiazepine sleep agents, which may increase the risk for dementia, and there's controversy over that, there's at least one study that suggests low-dose trazodone, which is what we use for sleep, may actually decrease dementia risk in the long term. There are some anti-inflammatory effects of trazodone at lower doses. So vilazodone is Qelbree, which is FDA approved for ADHD. So Sniper Channel has another question. He was put on 80 milligrams of atomoxetine and 20 milligrams of fluoxetine. What do you think about this combination? Again, my thought is, if it works for you, great. The beauty of having a separate serotonin reuptake inhibitor in the fluoxetine and the Strattera, atomoxetine, a norepinephrine reuptake inhibitor, is that you can titrate one or the other to the dose that's effective for you. If a specific combination worked well, it might be that duloxetine works better. What I'll say is and most doctors, including most psychiatrists, aren't aware of this. So fluoxetine, one of the first SSRIs, came out. Eli Lilly made it more than 30 years ago, or about 30 years ago, it emerged. Eli Lilly's own data showed that for depression, 6 milligrams a day worked as well as 10, worked as well as 20, worked as well as 40, worked as well as 80. Same percentage of people were helped, and they were helped to the same extent. Marketing and I don't know what other reasons caused them to only sell a 20 milligram dose for a decade. Then they've gone both higher with bigger doses for a weekly regimen and lower doses. And most of in the test tube research suggests at close to 6, somewhere between 6 and 10 milligrams, for most people, you've probably fully saturated the serotonin reuptake system. So bigger doses, you're likely to have more side effects over time. But again, if it's working for you, most people, the majority, don't have a problem with 20 milligrams of fluoxetine. If you are having any serotonergic side effects, I would try dropping down. And if you want the ease of a single pill, it may be that 60 milligrams of duloxetine does what those two drugs do together. So Max is sharing that alcohol does bad things to the brain. It makes him more anxious and down the day after he used it. So that's I was talking about alcohol and anxiety, where we have some amount of research. There's very little looking at just the acute effects of mood and alcohol on but my experience was that virtually every person with depression that I dealt with, by the time they were 40, and not necessarily younger people, but by the time they're in their 40s, as little as a single beer, a single glass of wine, or a single shot of hard liquor, all those have about 1 ounce of alcohol in them, so they're roughly equivalent. That would have a negative effect on mood, again, not while you're drinking it, but 1, 2, 3 days later, so in the 24 to 72 hour period. Whether this is what's going on or not, I think it is. This is speculation, to be clear. That's about the same time. So we know alcohol not just randomly kills brain cells, but there's certain parts of the brain that are particularly vulnerable. The hippocampus is one of those that's more vulnerable to the effects of alcohol than other parts of the brain. When hippocampal cells die, they don't drop dead instantly from that dose of alcohol. They're dying over about 24 to 72 hours. So a couple things. One is most people in Western countries who are social drinkers are drinking a few times a week. They never can tell what the effects of a single glass of beer or wine are because there's no clear baseline. So if they're not ready to stop completely, I say, let's just do an experiment. Let's just have one day a week where you drink, and not to excess even then, Wednesdays, and I will predict that Thursday, Friday, Saturday, you'll start consistently seeing lower mood. Again, this is for people who already have depression. Clearly, lots of people can tolerate moderate effects of alcohol without major health effects, but anyone who already has depression is already killing off cells in their hippocampus. So my take is alcohol and depression, or alcohol and anxiety together, are doing a double whammy on the hippocampus. And the hippocampus is one of the areas that can make new brain cells. When you're younger, you have a bigger buffer, more reserve. You may be able to not see the damaging effects of alcohol, but the older you get, the more likely you are to see the effects. So Sniper Channel is asking about duloxetine and atomoxetine together. So I don't know if I misspoke or was unclear. So yeah, so duloxetine is a serotonin and norepinephrine reuptake agent. Atomoxetine is basically a pure norepinephrine reuptake inhibitor. I would not combine them, but again, I think someone was asking about atomoxetine and fluoxetine together. So if I misspoke, I'm trying to clarify. Some people, if you particularly needed more banging away at the norepinephrine end of things, it's not bizarre to go with duloxetine and atomoxetine. You might try milnacipran, which is either Savella or Fetsima, which gives a stronger norepinephrine than serotonin effect. But again, in one pill, it's a dual serotonin and norepinephrine reuptake inhibitor, doing both. Yeah, so I mean, if you drink occasionally, I would sort of monitor what effects you can see, and again, particularly not just when you're drinking, but for 1, 2, 3 days after. If you don't have an extensive history of depression or anxiety, and you're not seeing a problem, then that may be okay for your brain. So Mr. AKA asks, what do I think about the role of nuclear imaging like SPECT scan and non-nuclear imaging like quantitative EEG in psychiatry? One neuropsych says 35% of his ADHD quantitative EEGs show non-ADHD neurophysiology. So this is probably worth the whole talk. So I'll tackle SPECT first, and there's a certain West Coast psychiatrist who's clearly a bright guy, clearly a very effective salesman who has been pitching SPECT scans and PET scans for diagnosing ADHD. He's written numerous books, and one he claims there's 7, another 12, another 19 different distinct subtypes of ADHD, all identifiable by PET scans or SPECT scans, what part of the brain is activated or lit up. There's probably kernels of truth in what he's doing, as in kernels of truth in the quantitative EEG, and yet other laboratories, other respected scientists don't replicate what he can see or claims to see as distinct thumbprints or identifying scans for specific types. Part of it is that the same areas on brain activation functional MRI tend to light up, seem to be aberrant, whether it's schizophrenia, depression, ADHD. It's the same frontal cortex, it's the same amygdala, it's the same anterior cingulate cortex. There's several areas that seem to be affected by lots of our conditions. So right now, we do not have useful diagnostic tools in either brain imaging or EEG to differentiate different conditions. I'm aware that there are certain psychologists and psychiatrists who believe that EEG may lead in that direction. I'm not saying I think eventually we will get more useful information, but I'd say a lot of what comes from these labs right now, at least from what I've seen clinically from patients, has been worthless. And the studies are really unimpressive in terms of differentiating similar conditions from each other. That's what I'll say. So when a neuropsychologist says 35% of his ADHD quantitative EEGs show non-ADHD neurophysiology, my first question would be, in addition to ADHD, or does that mean there's no ADHD neurophysiology? And again, that presumes we have completely mapped out the EEG profile of ADHD, which I don't think anyone's done. So, yeah, so Max is lamenting the legality and ubiquity of alcohol, and I'd say yes. I think if more people understood its harms, it would be less available. And what I would say is, from what we can see, the longer you abstain, the better off your brain is. So brains do have some potential to recover. So yeah, so Mr. AK7 sounds like we're back on the quantitative EEG. He says that these individuals whose brain wave pattern looks not like ADHD are the ones who don't respond to stimulants. Well, I would say, great, write that up and you get that into any psychiatric or probably even general biological science journal on the planet if the results are that striking. And that would be great and useful, but until it's published, until people are replicating it, until you're really making useful comparisons, I will say that, again, in general, the research out there doesn't support that it's useful yet. And clinically, I have not seen any individuals who gained useful information from those approaches. I can go into that clinically as well, if that's interesting. Hello, Dennis. So Dennis asks, occasionally I can sense bugs crawling on my skin in the absence of actual bugs. I'm hesitating about mentioning it to my psychiatrist in case I lose my concerted prescription. What do you recommend? One is I'm always encourage people to be as candid as they can be with their prescribing doctor, because if there are, what I tell my patients is I need to know, one, first of all, what you've actually taken, knowing that what I prescribed, you might have forgotten, you might have scrambled the directions, you might have lost. So I always need to know at the session, what did you actually take? And then two, what did you see, both good and bad? Because if I don't know, I can't help you minimize problems or optimize good things. And I apparently have a less judgmental presence or attitude about what's okay for you to have taken or not taken and what you're doing, so people feel comfortable talking to me. So there could be lots of different reasons for sensations of bugs crawling on your skin. It is one that's been associated with stimulants. Without, again, making a clinical judgment, if you're not having anything that's suggestive of hallucinatory, if you know that they're not actually bugs, that's really good. So I might actually bring it up first with your doctor, not by describing it or feeling that bugs crawling on your skin, but trying to describe the sensation or what it is you're feeling more than because I would say the feeling is one thing, the saying that it's feeling like or sensing like blood crawling on your skin is moving towards an interpretative description, and I would try to be using a more neutral description to see what it's. So I'd say light, moving around, jumping, if it's itching, if it's, I don't know what other aspects or how I would try to describe it. So I'm usually a big fan of communicating as directly as you can with your provider. So TM says he's become sensitive to caffeine. Are there stimulants I should steer clear of in the treatment of ADHD? So I did earlier in this Q&A go fairly long about caffeine sensitivity not necessarily being, that there's some general overlap or some slightly increased likelihood that you may be sensitive to prescription stimulants, but it's certainly not a guarantee, and there's lots of individual variations. So the approach would be to start slowly and see what you get, and if it's bad, stay away. Guanfacine, which is a non-stimulant, FDA approved for ADHD, starting that first often makes stimulants more tolerable once guanfacine is stable and in your system. So, and in terms of what should a physician look for in regards to recommending a cardiac workup before stimulant medication? So the Cardiology Association has said that a thorough history to make sure you haven't had fainting episodes or other episodes that may be related to poor cardiac health, and a good family history, if those two alone are benign, the risk of cardiac problems in someone, an otherwise healthy adult starting stimulants, is so low that it is not medically indicated to even get an EKG. On the other hand, if you're particularly worried, if there is any suggestive family history, that would be the starting point, is to get an EKG done. I guess that's so. At least in America today, there is to a very great extent, there's a lot of cover your ass medicine where people order all sorts of tests just so that if something bad happens down the road, they are not to blame. The benign framing of it is that they care deeply about their patients and don't want anything bad to happen to them. But again, if the cardiologists themselves are saying EKGs are not routinely required or suggested because the likelihood of them turning up anything is quite low, and again, without any family history or personal history, then I'm comfortable with that. So Mr. AKA asks, and I'll have to finish in about 5 minutes here. What does the literature say about SNRIs versus norepinephrine reuptake inhibitors versus serotonin and norepinephrine reuptake inhibitors for ADHD? To my knowledge, there is not a single head-to-head study. And without that, even using sophisticated statistical techniques, I would be very dubious about drawing comparisons. I mean, because we don't know whether the patient populations are the same. We don't know if they're given the same instructions. We don't know if they're monitored to the same extent for side effects or benefits. We don't know if it's separate studies, it's hard to make head-to-head comparisons. But when people are doing meta-analyses of what works for ADHD, again, the experts all say stimulants work better than non-stimulants. Stimulants way up here, everything way down there. What the data actually shows is it's Adderall, amphetamine products, highest rate of success, help the greatest proportion of people, reduce symptoms to the greatest extent, and all the others, including Ritalin, methylphenidate, are lumped below. Now, in many of the lumpings, And that lump below, it's hard to discriminate statistically whether one is better or more effective in general than another within that class. So there are more studies on atomoxetine because it's been FDA approved for ADHD, but the atomoxetine and duloxetine cluster, and even venlafaxine, which is weak on norepinephrine, cluster in the same region in terms of percentage of people who are helped. And they're not much different from Ritalin or Wellbutrin. So that is my interpretation of the data, but there are several meta-analyses where the summary looks like that. So for those who weren't here earlier and who are looking for the CBT panic video that I did record, I thought I uploaded and scheduled to come out Saturday, and then found out while I am away from home that it was not uploadable. So I will try to resolve that over the next few days. This coming week, I will be releasing a pre-recorded talk on stomach acidity and whether that has a big impact on absorption of stimulants or not. And hopefully, so that will be out on Saturday, and next Tuesday will be another Q&A on that topic or anything like today as well. So stay healthy, stay happy. This is Honolulu in back of me right now. Not my island in Hawaii, but I will be home tonight. That's all. Just glad that you're all here, and thanks for the good questions.